I've started recording.
Great, thank you. Hi everyone, thank you very much for coming to the 8th webinar on our physical activity series. My name is James Burgess. I'm a sports and exercise medicine registrar and GP based in Birmingham. We've got a really good lineup of speakers today talking about physical activity in relation to cardiovascular health and diabetes. If you just a few sort of ground rules before we start. We've got 3 sort of speakers today. When the speakers are speaking, if you do have any questions or comments, you put them in the chat box. When the speakers are finished, we can come to those and they'll try and answer your questions, and we can sort of highlight some of the comments as well. An email will be sent to you for some feedback, but I'll also put a link as well in the chat, so because we really welcome your feedback. And just to go to the next slide, we also have got the Healthy Brum YouTube channel as well, where all of the webinars will be uploaded to as well. So in case you miss anything at all. I'm going to pass you over to Dr. Parth Narendran for the first speaking again.
Thanks, James. I just need to share screen.
Yeah, I'll just take that off. Sorry.
Thank you.
There we go. Sorry about that.
No problem. I don't know if people can see that.
Yeah, that's fine. That's fine, Dr. Narendran. Yeah.
Perfect. Thank you. Thanks, James. Thanks for the invite to speak. So I'm based at the QE hospital in Birmingham and also do some work at the University of Birmingham. And my interest is in type 1 diabetes. I'm an adult physician and also a strong interest in exercise in the context of type 1. So thanks for inviting me to come and talk. So type 1 is only 1/10 of the prevalence of type 2. So our prevalence of type 1 is about 0.3%. So a smaller group of smaller population, but still a very important population to look after. Let's just see if I can move this. Okay, so what are the health benefits of exercise in type 1 diabetes? So because there are fewer people with type 1, this has not been studied as well as in type 2. But we do know that exercise makes people fitter. Can people see my screen? My cursor?
Just have a look. Yeah, I can see the cursor. It's a big sort of black arrow. Yeah.
Fitness, it reduces their insulin requirement, it improves lipids, it reduces mortality and cardiovascular disease, and mental health improvement is there as well. There's a lot of things we don't know though. We don't actually have any good data that it improves glucose control in people with type 1 diabetes. We're not sure what it does to blood pressure. Does it reduce cancer as it does in outside the context of diabetes? And does it reduce microvascular complications such as eye disease or kidney disease? But nonetheless, there are some clear benefits that we should be promoting, and we do try and promote this in our patients. How much physical exercise do people with type 1 diabetes undertake, and are there any barriers? So most of the work here has been done through questionnaires. So these first 4 bullet points are questionnaire studies where people have been asked to fill in from memory how much exercise they've done. And generally, we tend to overestimate how much exercise we do. When it's actually measured formally, as we've done here, and I'll show that in the next slide, what we see is that generally people with type 1 diabetes are doing about 1/3 less than people without type 1 diabetes. So here's data for type 2 diabetes, average minutes of moderate physical activity done per day. People with type 2, and Ewan might want also to comment on this, are doing less than people without diabetes. And in type 1 diabetes, we're seeing a similar thing, significantly less. And when we sit and ask them why this is, many of them, they come out with the sorts of things that we may come out with. So we're not motivated. There's the cost of the gym, the weather. We've got lots of family and work commitments. But there are also some specific barriers relating to type 1 diabetes. And I'm going to outline this a little bit clearer in the next slide. So Here are the barriers that are specific to diabetes in new onset type 1 diabetes and in established type 1 diabetes. In new onset type 1 diabetes, the barriers, common barriers, hypoglycemia, fear of their blood sugar falling. They also cite lack of knowledge and confidence in managing their diabetes around exercise. Sometimes healthcare professionals are guilty of telling them to stop exercising when maybe this is appropriate in the context of someone who's just been admitted with new onset type diabetes. They cite the fact that they need to do quite a lot of planning, like checking their blood glucose, and around the time of diagnosis, feeling overwhelmed by the whole thing. With established type 1 diabetes, hypoglycemia is not really there in the top few reasons and barriers to exercise. What they do describe is loss of control of diabetes, and I'll come on to that later. But also they cite lack of knowledge on how to manage their diabetes for exercise, similar to that. What are the things that can be done to facilitate exercise? Well, from the healthcare professional, greater levels of knowledge about how to advise patients to exercise and encouraging them to exercise that diagnosis. From the patient, they'd like to know a little bit more about how to manage their glucose around exercise, better educational material, and help with goal setting. And in terms of interventions, things like supervised classes and access to fitness advisors were cited as being potential facilitators. So those are people with type 1 diabetes. What about the healthcare professionals? So we went to health because one of the barriers was that often healthcare professionals don't provide the sort of advice that's needed to manage the diabetes around exercise. We did a survey of about 162 healthcare professionals, combination of dietitians, doctors and nurses, all in secondary care, and asked them, how confident are you in advising your patients to manage their diabetes around exercise? And yellow and blue here are confident and very confident. And generally, on most of these topics, they generally felt pretty confident in supporting their patients. However, when we actually asked them, having collected that data, the next part of the questionnaire, we actually put specific questions to them around how to manage different aspects of diabetes for exercise. And I think you'll see that the levels of knowledge were actually very abysmal. So in terms of, in terms of where to inject for exercise, so generally we say, if you're running or using that muscle group, try not to inject your insulin in that group. A lot of people weren't aware of that. How do you adjust your rapid-acting insulin or basal insulin for exercise? A lot of people weren't aware of that. What to do for specific blood glucoses, people weren't aware. So whilst we are encouraging our patients to exercise, there's specific barriers that we're not able to help them with. And the worrying thing is that we're actually confident and we feel we're good at supporting them when actually we're not. But I think the one bit of they did have a bit of insight, and 89% of respondents did want more formal education on how to manage diabetes for exercise. So what happens in the real world? So I'm just going to tell you about the EXTOD 101 study. The EXTOD studies are a group of studies that we put together, and they stand for exercise in type 1 diabetes. The O of TOD is for 1. And EXTOD 101 is a study that we did in 2018, looking at people who were participating in the Swansea Half Marathon. And it was meant to be a record-breaking attempt to get the most people with type 1 diabetes to run the half marathon. The aim was to recruit 101 people to do that. We didn't quite get there, but that's where the name derives from. So it was a pretty simple study. We didn't intervene in any way in the way they managed their diabetes for exercise. So people were enrolled. About 6 weeks before the event, we sent them a questionnaire, did some home testing of HbA1c and cholesterol and a few other things. Sent them some diaries and also 3 Freestyle Libre glucose monitors that they wear. Each Freestyle Libre lasts 2 weeks, so that would take them right up to the event. We've asked them to record what sort of exercise they were doing. Then there was a half marathon event itself. through which they wore the Libra. And then there was a 2-week detraining. About 60 odd people took part in the event, but only 34 entered the study. 40% males, mean age of 45. Generally long-standing type 1 diabetes, almost 20 years of type 1 diabetes, generally well controlled with an HbA1c of 57, and our target is 48 to 58. Undetectable C-peptide, which is a measure of how much insulin they're still secreting. Some of them, though, did have some residual insulin secretion. Cholesterol reasonably controlled, and the vast majority did have awareness of hypoglycemia. We asked them what sort of training they did, and it's interesting, almost all of them did do some running as part of training for their half marathon, which is reassuring, but they did lots of other types of exercise, including badminton. So one of them put painting as a training for their event, but hiking and golf and all sorts of things. But they all did some sort of running as part of their training. And this is their glucose control. So this is something that's called a Violin Plot. And this is 0 going up to 120 percentage time in range. And the different ranges here are glucose values less than 7 to 15, which is where we'd like them during exercise. This is the international consensus guidelines for where glucose should be when people exercise, and over 15. And these are for the 3 periods: training, during the event, and detraining. And what we see is that in the training period, there's a lot of people who are below the range that they should be for exercise. And over 15, the mean is almost 0, so very few people are running themselves high. During the event itself, they switch to having a higher glucose level. Very little here below 7, but most people running between 7 and 15, which is in target or above. And in detraining, they come down a little bit. And we sort of see this when people are going through an event in exercise, they tend to run themselves high to make sure nothing wrong happens. And we think this is largely a behavioral thing. Our glucose levels do go up with any stressful event, but we don't think that's the cause of this, because it wouldn't account for the raised glucose for the entire half marathon. And here's a case study. So here's a 19-year-old person, slightly overweight, 14 years of type 1 diabetes, very good diabetes control, and hypo-aware. He completed the half marathon in 117 minutes. He recorded 10 episodes of training, of which 1 was running, and he did a lot of the training using other types of exercise. And we see the same thing. So here is time above range, above 15, and during the training, very little of the time is above range, and during the event, he's running himself high. But then between the event and bed, and we could see this on the Libra trace, he did drop his glucose, and that does happen after exercise because a lot of the glucose stores have been used up during exercise and people are at risk of hypoglycemia. He did drop, and this ended up in an ambulance call out for him with a severe hypo. So in summary, individuals with long-standing type 1 diabetes have different approaches to half marathon training, and they generally tend to run themselves high during an event, but this doesn't always protect them from hypoglycemia. And then whilst this wasn't recognized by the Guinness Book of Records, this still was the largest number of people with type 1 to run a half marathon. So that's what's happening in the real world. So, there's lots of different approaches, not all of them are working, and people are finding it challenging to keep themselves in the correct glucose range during exercise. How can we best support people with type 1 to manage their exercise, manage their diabetes for exercise? And this is work we've now been doing for about 10 years, and we're all under the umbrella of EXTOD. So we've been running the conference now for about 8 years, which is for healthcare professionals. We run it with JDRF, which is a Type 1 Diabetes Charity, as well as the Association of British Clinical Diabetologists. And we've kept this in secondary care, and Ewan this might upset Ewan, but a lot of type 1s are actually in secondary care. So we focused it there, but this is, the conference is open, of course, to everyone, primary care as well as international attendees. We have a website called EXTOD.org, which goes through a lot of the principles for managing diabetes around exercise. And then more recently, over the last 5 years, we've been doing a study to develop a structured education program to support people to manage their diabetes around exercise, and funded by the NIHR. So it's a two-stage program. First was a needs assessment, where we did a literature search, an online survey of the current advice and knowledge, interviews with healthcare professionals and people with type 1 diabetes. We developed a curriculum. We included this into a sort of theoretical, philosophical framework for the intervention. And we developed an education program that went through a number of iterations between 2016 and 2017. This was then used, this was finally used to educate people with type 1 diabetes to manage their exercise, and finalized. And then we had a final program that was ready for testing in a pilot randomized control trial. So this took the best part of about a year and a half in order to optimize the education program. And it went through different things. The fact that different exercises do different things to blood glucose. So with some exercises, blood glucose stays the same. With long distance running or cycling or any aerobic exercise, our blood glucose tends to fall. And then with any stressful exercise like weightlifting or a 100-meter sprint, in people without type 1 diabetes, well, in everyone, there is a surge of adrenaline and noradrenaline and cortisol, which pushes our sugar up. In people without type 1 diabetes who are making their own insulin, the insulin secretion does go up at that time to bring the glucose back down. But in people with type 1, they don't have that check, so their glucose tends to rise. And then in mixed exercise, the sugar can go either way, depending on the combination of whether there's anaerobic or aerobic. So, a lot of our patients will come to us and say, when I do archery, my blood glucose goes up. It's a real problem with squash, actually, managing the hyperglycemia. Aerobic exercise, I say, tends to drop it down, and flexibility exercise doesn't really do much unless it's a prolonged exercise session. So using that understanding, people can actually change the type of exercise to manage their glucose. So one of the people who went on the course would say that when he goes to the gym, if he has a high blood sugar, he'll start with his aerobic exercise and finish with his anaerobic. So that'll drop his blood glucose, and then the anaerobic would lift it. Alternatively, if he has a low blood glucose, he'll start with anaerobic exercise and finish with aerobic. And people can also use this in a run, for example. So during a 10K run, if they found that their glucose was falling, they might do a quick sprint to bring their blood glucose up. So these are little tools that people can find useful. We also go over the risks of hypoglycemia at different times of the day. So running in the morning and running in the evening, the same distance and the same speed. If you run in the morning, you're less likely to have a hypoglycemia because you're awake later on in the day when the glucose level may fall, and therefore it's easier to pick up the hypoglycemia. But also we're more insulin resistant. We have a cortisol surge in the morning that makes us more insulin resistant. So the risks of hypoglycemia are lower if we do the same exercise before breakfast. We give them a sort of flow chart with a golden glucose range of 7 to 15 to start, and what to do if your glucose levels are lower just before you start, or higher, and checking for ketones. We also talk about the effect of exercise on insulin sensitivity. So going back to that questionnaire, where people with long-standing type 1 diabetes often ask, whilst they are concerned about hypoglycemia, it's not a big issue for them. But what is an issue is the fact that it disrupts their glucose control for a few days. And it took a while for us to understand this, but generally, when we exercise, we become more insulin sensitive. So here are insulin secretion rates in someone who doesn't exercise. So here are your breakfast, lunch, and dinner, and then back down to normal. So here are 5 days. If we were to exercise, we become more insulin sensitive. So we don't need to secrete as much insulin for our meals or in the fasting state. And then it takes a couple of days to go back to normal, which is why the government guidelines of don't go for more than 2 days without exercise, because it takes a couple of days for the insulin sensitivity to get back to normal. So regular exercise keeps us insulin sensitive through the 5 days. So you can imagine someone with type 1 diabetes is going to have to try and replicate this. They'll have spent a long time getting their basal rates correct and then their meal rates correct. And then they exercise, and for the next day, everything goes out the window. They've got to change their basal insulin rate, and they've got to change their mealtime insulin rate. So we talk to them about how to do that. So we've got to reduce the quick-acting insulin by 50% for the next few meals, reduce the basal rate by 20% for the night after the exercise. So we put this all together and deliver it in 3 sessions, each lasting half a day, and with time in between to go and practice the different techniques. So it starts off with 8 people sitting in a room, going around talking about the different types of exercise they do, and what their main problems are. And then we go through all the mechanics and different strategies for managing the glucose. And we took this through a randomized controlled trial. So we took almost 100 people with type 1 diabetes, recruiting from the Southwest as well as Birmingham, did some starting measures, randomized them to either usual care or the EXTOD education program, and then repeated the 6 monthly measures. And what we found was a very clear improvement in quality of life. So quality of life went up if they received the program, but went down if they didn't. Diabetes distress also improved. And hypoglycemia decreased significantly. So, and what was really sort of fulfilling as a healthcare professional were patients coming back to us and saying we could do 10K, but we never could run more than 10K without having hypos, and this has allowed us to do that. We had fairly high level cyclists who could do 100 to 200 100K bike rides, but couldn't get it up to 200K. So teaching some of these techniques really helped them to do that. And this isn't just for elite athletes. So we had people who did lower levels of exercise, but maybe a lot of their exercise was around spring cleaning. We had someone who was a cleaner as a job, and she found hypoglycemia very troubling and didn't quite know how to manage that. So a lot of the techniques we were able to support them with was useful. So currently we're in the plan of setting up the service at selected sites. The program has been adopted by Wales as their national program for exercise in type 1. We're also working with Open University to put this online so that there's greater access. So in summary, there are many benefits from doing regular exercise in people with type 1 diabetes. However, people with type 1 are not reaching their targets and are far less active than their healthy peers. A key barrier is education, and they're not getting enough of it, and healthcare professionals are often not equipped to support their patients. And structured education programs for exercise appear to reduce hypoglycemia and improve quality of life. So with advice and support, people with type 1 can and want to undertake physical activity levels. And Steve Redgrave is a reminder that diabetes needn't be a barrier to exercise. And I think most Olympic sports now are represented by someone with type 1. And these are all the people who've contributed to this. So a lot of people from Taunton, Leicester, who helped develop the education program, a lot of people in Birmingham, and others, and of course all the study participants. Stop there.
Thank you very much, Dr. Narendran. That was a really fantastic talk. Really, it's unbelievable what they did with the half marathon, and just with the benefits that EXTOD has provided as well. That was really it's been fantastic support, and great people on the call today. Just signposting people with type 1 diabetes or working with people with type 1 diabetes to EXTOD would be a really beneficial thing, I'm sure. I've got a comment there from Lisa, who's one of my colleagues, a sports and exercise medicine registrar, to yourself, Dr. Narendran. I don't know if you can see the chat, just because. Yeah.
Thank you. So yeah, Lisa's question. Thanks, Lisa. Yeah, so we generally say 30 grams of carbs. So, you know, we have different levels of advice. So our first bit of advice on the carbohydrate front is 30 grams of carbs for every hour of exercise. Sorry, for every 30 grams for every half hour of exercise. And we do recommend testing. A lot of people now do have the Freestyle Libre, and they can try and use that during exercise, but generally we're saying testing every half an hour during exercise. The three principles that we talk about for managing glucose around exercise. One is carbohydrate, as you raised, and that's the commonest one that's used. But also reducing insulin doses is a useful approach. Taking extra carbs does put weight on. A lot of our patients do want to lose weight, so it's a bit counterproductive. But so they might want to use the option of reducing their insulin. And the other one, of course, is to change the exercise type, which I mentioned in the talk. And in terms of how often you'd want advising ingestion, so every 20 to 30 minutes, often as a fluid. So you're rehydrating, so Lucozade or something.
Great. Thank you very much, Dr. Hendren, for that, and thank you, Lisa, for the question there. Thank you very much again to Dr. Hendren for a really fascinating talk there. And I'll pass you across to Ewan Hamnett, who I've been fortunate to work with recently during my time in public health for a number of different projects. So thank you, Ewan. Dr. Hendren's put his details there in the chat for anyone that wanted to.
Can you hear me?
Get in contact as well, just for let everyone know that. Yeah, I can hear you, Ewan. Yeah.
Perfect. All right. Can you see my screen?
I can see your screen. Yeah.
Oh, good.
Thank you.
All right. Let's hope it progresses. There we are. Right. So thank you, Dr. Hendren. Really interesting stuff that about exercise and physical activity. And I think this applies to type 2 diabetes. And type 2 diabetes is driven by insulin resistance. One of the really interesting things here is I'm not quite sure who I'm talking to. And I'm hoping that somewhere in the audience there will be a handful of people who perhaps have type 2 diabetes or overweight or want to reduce it. If not, it's not a problem. But this talk is largely aimed towards those people, but hopefully it will be of use to public health colleagues, because what I've tried to do here is to really wrap up the consensus of type 2 diabetes and how it is curable and how we should be preventing it. It is to me just a massive nonsense that we have so much type 2 diabetes, but it's not the fault of the type 2 diabetics. It's very much the fault of the society we created in terms of the environment, in terms of the food environment and all that sort of stuff. So this is not personal. And as I said, when I was a GP, I'm there to give people information. Quite what people do with this information is up to them. But hopefully, after this, these few slides, you'll be clearer on how to prevent and cure type 2 diabetes. Oh dear, hang on. It's not forwarding. Okay, there we go. Right, so inactivity is twice as likely to kill you as obesity. You just can't put people on scales and weigh their activity, which is why I think there's such a lot in the press about obesity and relatively little about activity. But activity is absolutely fantastic, and it reduces your risk of just about everything that you could possibly get. You'll see in the next slide. So dementia 30%, depression, hip fractures, you name it. It reduces inflammation. So in terms of heart disease, it will reduce your inflammation in your coronary arteries. It will reduce inflammation in your brain, so reduces dementia. Reduce inflammation in joints, arthritis. It's just the best thing. But you have to ask a sort of question. before we start, because you've got to know a bit about fat. And I will use the F word. And I love going to talk to medical students, and I say, well, where does fat go? And they go, oh, well, it dissolves, so you metabolize it away, and da-da-da-da-da. It's really very straightforward. You breathe it out. So you take in a bit of oxygen, and it disappears to carbon dioxide and water. Fantastic. COVID, I couldn't do this talk without talking about COVID. And I think if we just park the horrendous decisions made by the government early on that accounted for 130,000 deaths or some of it, there are two other reasons. One is the lack of capacity NHS, because it's always been about protecting the NHS. And once the NHS is full, there's nowhere else for people whose lives have been threatened to go. The same could be said of schools. If schools had 15 people per class rather than 30, it would have been easier to manage schools. But the other thing is the state of health of our population. It's not good. We're approaching 70% of our population now overweight or obese. And the most recent Sport England figures show that 11.7 million people in this country, 11.7 million, are doing less than 30 minutes of activity per week. And that's actually got worse during COVID. All these pictures of people in middle-class areas going out for walks and bike rides in the streets. But actually, for the bulk of the population, this has been really difficult to be active. Issues around motivation and not using public transport, which is of course a good source of activity. All this sort of stuff matters. So we have to sort of realize that the people that have been dying from COVID aren't new people. They've just been dying earlier in the life trajectory and more quickly. Type 2 diabetes is a marker of poor health. So 90% it was caused by 5 things: poor diet, obesity, inactivity, smoking, and too much booze. It cost the NHS a shed load of money. And in some parts of the city, places like Neachel, Sparkbrook, up to 1 in 5 of adults have the condition. One of the shocking statistics is if you look at gestational diabetes, this is when, because of things that Parth talked about, things like cortisol and stress levels during pregnancy and all sorts of stuff, diabetes will often manifest itself during pregnancy. And when I started, I qualified in 1980, and at the beginning, you rarely saw gestational diabetes, but now between 8 and 24% of pregnant mums will have diabetes. And I think all we need to do is take a walk around the bull ring and have a look at the shape of, won't say the average 20-year-old female, but there's a significant problem there. And there's a generational decline going on, which is, I think, why, what we're seeing now is just the tip of the iceberg. Weight gain and diabetes are very closely related. So if you've got, if you look like a rake like I do, a BMI of about 22, my chances of getting type 2 diabetes are really small. And that's despite my father and my grandfather having type 2 diabetes. I'm so far okay. My HbA1c is 35. If your BMI rises to over 35, you've got an 88 times the risk of getting diabetes. So it's just about linear. But there is good news. And the good news is if you lose weight, the diabetes goes away. So this is the DIRECT trial, which was 2017, where they gave people ridiculously small amounts of food for about 13 weeks. And lo and behold, if you lost 15 kilograms, 86% of those people with diabetes went into remission. And I think of curing diabetes, I think it's a reasonable statement. And some people can test that. But if you're overweight and you weigh, I don't know, 110 kilograms, and then you suddenly weigh 70 kilograms, do you go around the rest of your life saying, I used to be fat? Or do you say, no, I'm now thin? And I think we can use a similar analogy to type 2 diabetes. But here's the question. So if you're inactive and overweight, where do you start? Because if you're inactive, you're more likely to be overweight because calories, But if you're overweight, you're more likely to be inactive. You'd be embarrassed to go to the swimming pool. It's just physically difficult to get out and do things. So the two things work against one another. So the question is where you start. And although activity is much, of the two, it is far better to be active than to be overweight in terms of reducing overall mortality. Diabetes is a little different. And I won't bore you with science, but if you looked at the subgroup analysis from a guy called Eklund back in 2015, subgroup analysis showed if you've got type 2 diabetes, it is better that you at least start with losing weight. But obviously, if you start losing weight, you will obviously then start to become more active because you start feeling better about yourself. The reason I put this slide up is that lots of people engage with activity thinking they will lose weight. Now, some people will achieve weight loss, but most don't. And the problem with this is you give up on the activity saying, well, that didn't work. I'm not going to try exercise again. But just be active because being active is really good. Generally speaking, though, when you get active, you exercise more, you feel a bit more hungry, eat more, it kind of balances out a bit. Similarly, if you take yourself on some crash diet and you go on 800 calories for 3-4 weeks, you feel pretty tired and you'll often exercise less. So it tends to be a bit more neutral than we might intuitively think. So what is a good diet? I'm going to talk about the climate because the climate crisis, because nothing else matters, but only just for this slide, don't panic. So a good diet, for me, is the same for the planet as it is for us. So basically, low in meat or no meat, high in fiber. The rest you can argue about, and we won't go into details. But this is an interesting slide. So what this slide shows, if we flick the switch tomorrow on the 160 countries that were studied, if everybody adopted a Western-style diet, carbon emissions would go up 135%. If everybody became vegan tomorrow, carbon emissions would drop 17%. Beef is a disaster. You can watch things like Cowspiracy and, all sorts of stuff if you want confirmation of that. But beef and other red meat is a disaster, both for the planet and also there's lots of our stuff from WHO about meat, and certainly processed meat being definitely not good for you. So this is just my Extinction Rebellion slide. All right, so forgive me that. Guy in the middle of this slide you may have heard of. This is David Unwin, and he's been championing low carb, healthy fat for ages. I know David quite well. He went for a run with his wife. He was pissed off as a GP when he was about 2012, 2013. Oh, I'm fed up with all these people. I don't know what to do. I'm not helping them. His wife said, well, why don't you do something positive? So at that point, he started thinking about metabolic conditions like type 2 diabetes and high blood pressure and raised cholesterol. And he said, I'm going to look at low carb, healthy fat. And that's what he's been doing so far. And he's now got a literal army of practitioners behind him. And hopefully your GP, if you have one, might be one of these. What does low carb look like? It looks like this. Interesting what Parth said about insulin resistance and it being higher in the morning. Insulin resistance is so what should happen with insulin is it basically should push glucose into your cells, store the excess glucose as glycogen or fat. But if you have your standard breakfast of cereal and toast and your insulin resistance, then you will fat store in the morning. If you take a breakfast that looks like that, and furthermore take a lunch that looks like that, and have a mushroom omelette, which has got remarkably few carbohydrates in it, this would be a low-carb diet. It may be a bit of a change for many people, patients or people listening to this webinar, but this is what a low-carb diet looks. It can be much more exciting than this if this doesn't float your boat. Have a look at Diet Doctor or diabetes.co.uk. Not Diabetes UK, but diabetes.co.uk. And these will tell you more about diet. This is not just about sugar. This is about what's called glycemic index. And people, if you look at the NHS guidelines, they do my head in, I have to say, because they say base your diet on a starchy food, pasta, potatoes, rice. And I think, goodness me, it's kind of missing the point that potatoes, pasta, they're all basically carbohydrate based. Your body breaks them down using the various hormones in your body, amylase, etc. And essentially, they end up as sugar. And if they end up as sugar, they will have to be processed somehow. And it's fine if you're an elite athlete and you're just burning sugar all the time, but most of the people are not in that. You also have to think a little about common things like fruit. 5 a day. In Australia, it is actually 7 a day. It's 5 vegetables and 2 fruit. And I would argue that your five a day should be largely vegetables where possible. If you take 500 grams of vegetables against the 500 grams of fruit, 500 grams of vegetables will have around about 400 calories. 500 grams of vegetables will have about 120 calories. So if you make your 5 a day more vegetables and fruit, if you are going to have fruit, make it UK-based fruit, berries in particular, have a much lower glycemic index. How does it work? Very straightforward. The guy on your right here was the caveman. He did lots of things pretty well, but one thing he did very well was to store fat. If he could store fat, he could survive his droughts, his wars, his famines, his diseases. He was more likely to survive, so he would pass those genes on to his children, and so on, and so on, and so on. So for hundreds of thousands of years, we evolved to store fat, but essentially since the Second World War, we haven't needed to do that. Unfortunately, our diet has, what's become available has become cheap, often carbohydrate-ridden, often got saturated fats, high calories. So we're now in a pretty disastrous situation because we still fat store. The other fellow we need to understand is C257, et cetera, that is insulin. What does insulin do? Very straightforward. What insulin does is the first thing it does, it feeds the cells. So we need insulin to push stuff into the cells for energy. We don't need that much glucose. The problem is, what do we do with it then? Well, then you've got two options. You've got storage as glycogen or storage as fat. And we're going to talk about glycogen storage in a minute. But a lot of people, they will store it as fat. And if you ask people an interesting question and you say, how many meals a day do you have? They say, well, I have 3 meals. If you ask them a slightly different question, you say, how many times a day do you eat? You'll often say, well, I have breakfast, and then it was Annie's birthday, so she brought some cake, and then I had my lunch, and then I thought I should have one of my 5 a day, so I had a banana, and then I had my evening meal, and I was a bit peckish before I went to bed, so it's something else. So that's eating 6 times a day, often carbohydrate driven. What you then get is you have excess carbohydrate, you secrete insulin, you store it as fat. You have excess carbohydrate, you secrete insulin, you store it as fat, and so on and so on. Does it work? Yes, it does. David Ullman's practice in Southport. He's got 470 type 2 diabetics. He's got less than that now. 188 chose to engage with low carb. 49% are in remission at 30 months. So that's long-term remission. They also lose significant blood pressure falls and cholesterol. Where does physical activity fit into this? Well, it fits in 2 ways. Certainly increases insulin resistance, it burns off calories, but the other thing is glycogen storage, and we don't talk about this enough. So glycogen is the third thing. So if you remember this slide, you'll see energy, glycogen, fat. So glycogen is kind of magic. So if you imagine you had a bank and you've got a bit too much money, and you put the money into the bank, and then you could draw it out when you needed to spend it. That's essentially what glycogen does. The problem with the bank is it's not very big. If you've got no muscles and you're sedentary, then your bank has only got the capacity to store about 400 calories. If you build up your muscle, you make the bank bigger. It goes up to about 2,000 calories. So that's why you need to build up your muscle. So that's really it. I thought I'd just give you the broad outlines. Be physically active, best thing you can do. It's easy to be active if you're slim. The low carb approach has an increasing evidence base. So the American Diabetic Association advocate that as the premier way to diet. Weight loss and activity will, as I said the slide earlier, will get rid of about 50% of type 2 diabetes if that's what you really want to do. And as a little summary, I did a Vimeo, which you can copy off this. It basically says what I've just said in a little amusing video I did for some local practices. That is it.
Thank you very much, Ewan. That was a really interesting talk, a really practical sort of, sort of knowledge about type 2 diabetes, and is it very interesting results actually from your colleague there, in terms of the reduction in people who actually had type 2 diabetes. It's fantastic. And also that holistic approach, I think that's important as well. I know this is about physical activity, David. It is about diet. It is about other things than physical activity. So thank you very much, Ewan, for that. If anyone's got any comments or questions, please put those across to us. I'm just going to pass you over to our last speaker today, Adam from the cardiac rehabilitation team. So thank you, Adam.
Thank you. Thank you all for inviting me today. I'm just going to try and share my screen with you. Can you see my presentation?
Not yet, Adam. No, not yet. So if you go on the share screen, sometimes it's like a screen button on the sort of. Yeah, that's looking good. That's perfect. Thank you.
Perfect. So thank you all for inviting me. It's a pleasure to be here. My name is Adam Sukia. I am the Cardiac Rehabilitation Team Leader of Community Cardiac Services for Birmingham Community Healthcare. I'm here also on behalf of Beverly Lenton, who's the Cardiac Service Lead. So basically my presentation today is to give you a bit of a snapshot of what we are and what we do. So half of our service is community cardiac rehabilitation and the other half is community heart failure, and there's a nice crossover between the two teams. We are a service that is secondary prevention, that accepts referrals from all the secondary care centres and primary care within the Birmingham and Solihull demographic. We're commissioned by the Basal CCG and we operate under the guidelines and standards of the British Association of Cardiac Prevention and Rehabilitation, the British Heart Foundation and NICE current guidelines. Our current patch delivers to the north, east and central Birmingham as well as Solihull. We accept referrals of people aged 18 years and over, and they all have had cardiac events, and this can range from bypass surgery to PCI, generic ACS, acute coronary syndrome, umbrella, valve surgery, heart transplantation, and obviously heart failure patients, as confirmed from the recent NICE guidelines for heart failure 2018 to include heart failure patients with exercise and rehabilitation. The structure of our service is kind of designated into what we call phases. We start with what we call as a phase 2 assessment, which is an initial assessment, either done in a clinic environment or a home visit. And this will include a full clinical assessment of medications, current exercise capacity and functionality. If patients come to any one of our clinic venues, they will have a functional assessment completed by one of our community cardiac exercise physiologists. Our initial assessment also includes education and lifestyle modification advice. My prestigious colleagues that have led the talks before myself have mentioned a lot about diet and exercise, and it's our job to kind of try and break down some of these myths and perceptions from some of the patient populations that come into our service from very different demographic and socio-economic locations within the Birmingham and Solihull area. So we try and establish some healthy behavioural changes right from the start, as well as trying to encourage people's exercise and knowledge empowerment participation as well. As long as people meet the criteria with our programme, we then refer them on to our what we call our phase 3 to phase 4 programme, which is the core components of our cardiac rehabilitation, which is basically structured exercise. As I'll go into shortly, we've been fairly limited on what we can provide patients over the last 12 months or so due to the COVID pandemic. Likewise, with a lot of our colleagues across the country and Northern Ireland, we try to adapt as best we can with the changing situation there with the coronavirus pandemic. So during the current COVID-19 pandemic, we've been able to deliver a basic skeleton pathway to people, but still an essential pathway to try and avoid admission to hospital and try and keep them out of hospital and manage their conditions out in the community. So we've still been able to deliver our clinic-based and home-based initial and exercise risk assessments and full clinical assessments. We've also still been able to deliver home visits as well, be it under strict COVID-19 infection control guidelines. In terms of exercise, we've explored various options during the COVID pandemic, along with discussing with our colleagues nationwide from different trusts, different cardiac rehab teams, both NHS and private providers, in terms of trying to learn what other people are doing during this difficult time. We've always been providing telephone support and advice to patients, that's always been an easy option, but it's probably highlighted during the pandemic the importance to explore and try and lead on virtual platforms There are existing platforms out there, there always has been. There's been a fantastic one which has been developed by the Leicestershire Trust called Activate Your Heart, which they were very kind to lend a free licenses out for a small trial period to any trust that was interested. And I think this program was very beneficial, but it depends on the demographic that you're delivering to. It's very reliant on people having access to technology to get onto these programs. It's not the sort of program you want to access through a smartphone. It's something that you need to access through a laptop or a desktop computer, or at very least an iPad, because there's a lot of information to read and understand in terms of education, not just on the talking points, but also on the exercise, health and safety points as well. We moved on from that and started to develop our own virtual cardiac rehabilitation pathway. We were delivering live sessions, live workout sessions to people via MS Teams. It was a learning process for us as well. We were pleasantly surprised at the amount of people of the older generation that did have access to technology to be able to engage with these programs, and we're very enthusiastic in doing so. We had a very good patient base to do the program in order to get a really good evidence base from it as well, to move forward with pre-recorded virtual rehab program as well as education as well. I'm pleased to say that we are now through the original restrictions now with COVID, and we've been able to return back to our gym-based face-to-face structured cardiac rehabilitation as of this week. In the Birmingham and Solihull demographic, we have various stakeholders, including Serco and extra care retirement villages, where we use their various gym facilities and leisure centres to deliver our programs. Excuse me, we deliver our gym-based programs twice a week, and we also deliver a group-based circuit program as well. We've opened up now to deliver cardiac rehab to heart failure, and this is following a good initial assessment from the heart failure team in order to refer over to us for their group-based exercise. As previously discussed, we're also moving forward with our virtual cardiac rehab and virtual cardiac rehab education program, which is via MS Teams and also the NHS-approved platform Attend Anywhere. We also signpost people to the service website for the Chart Foundation as well. We've also started to expand our options available to patients, including Tai Chi, which we offer a virtual and a face-to-face option. This has had a really good uptake. People that would probably normally never have participated in something like Tai Chi are finding it very beneficial, not for a specifically structured cardiac rehab perspective, but more from a social prescribing perspective, which is something that the CCGs are very hot on these days, as an introduction and a gateway into structured exercise, by just almost, for want of a better explanation, whetting people's appetites to engage in physical activity. So Tai Chi, although very low intensity, is a good introduction to getting people moving. We do both a standing and a seated version for this as well. We've also introduced an outdoor walking program, weather dependent, obviously. As we're starting to move into the milder weather and the lighter days, we are really pushing forward with this program, which is basically a supervised walking program, which we do at one of our stakeholders' leisure centres around one of the athletic tracks. The reason for that is it's a flat surface, it's easy to observe people all the way around. We can offer seating facilities for people to sit down if they need to and rest throughout. And we're finding a lot of our heart failure patients are really loving this pathway to at least introduce them into exercise. So discussion points kind of moving forward with us in terms of developing and evolving the service is that we're really looking to push forward and link with the primary care networks within the Birmingham and Solihull demographic, which kind of runs in line with the sustainability and transformation plans in the NHS long-term plan moving forward in order to manage more people out in the community and try and initiate some primary prevention rather than be reactive with the secondary prevention. I must admit, secondary prevention has been very successful up to date, but we'd like to try and prevent people having heart attacks in the future, needing bypass surgery in the future, and so on, by providing effective education and intervention at the right stage. But obviously this will need to be an evidence-based pathway in order to get it commissioned. Unfortunately, it all becomes about funding and resources at that stage. But we would like to provide some good pathways for early screening and intervention. And I think the education pathways we're starting to formulate, as well as the social prescribing. I'm not sure if everybody's got an understanding of what social prescribing is, but it's about more sort of getting people interacting with social interaction, maybe whether it be going to do a walking program, maybe working, doing some supervised allotment work, getting them to do sort of more realistic physical movement rather than structured exercise to try and break down perceptions and barriers for that as well. During my time within cardiac services, as I'm sure with any long-term condition, there's a definite importance and relevance for psychological input, and I think there needs to be an evolution definitely within the Birmingham area in terms of how we deal with the psychological effects of long-term conditions and how this can affect barriers to exercise as well. From a cardiac rehab perspective, we've been very focused on old screening tools like the hospital anxiety and depression score, which is quite inappropriate for Birmingham because of our massive ethnic population, and actually the transfer of this into different languages often gets lost in translation. So we simplify it by using tools like PHQ-9 and GAD-7 specifically for anxiety and depression, which is good as a screening tool, but obviously the conversations has to be what happens to these patients if they score high. There have been other pathways previously like Birmingham Health and Minds or the IACS, which is the individual access to psychological therapies, but I still think that there is gaps there in terms of intervention and support we can provide patients with psychological support. So kind of moving forward, we want to develop our long-term condition pathways and establish links with our other specialist colleagues in respiratory and diabetes, obviously. Working for a massive community trust such as Birmingham Community Healthcare, we have a huge array of other specialist services like diabetes, like respiratory, that we will be linking closely with the future, and also hope to link closely with the GPs in the primary care network. There is an ongoing cardiovascular disease steering group programme, which is being led by the British Heart Foundation and also the Basal CCG, to develop better pathways within Birmingham and more structured referral processes within secondary care, community and primary care. So there's no duplication, but it's a better use of resources moving forward. Other opportunities moving forward, we have a current project and trial going on, which is NHS at Home, which is being funded by the CCG, which is trying to explore more things like telehealth and telemedicine, and getting more evidence base around that moving forward. I know this is nothing new, it's nothing revolutionary, but there's definitely been an exploration and an identification for this to be sort of enhanced and moved forward with now. A little bit of a lighter note as well. During the pandemic, we were exploring all types of innovative ideas of how we can move forward to provide intervention effectively through a virtual format. And one of the opportunities we explored, I don't know if many people remember this guy, there's a guy called Mr. Motivator, or also known as Derek Evans, who is very passionate and keen in working with people overall nationwide and getting people into fitness and physical activity. And so we were exploring with Derek the possibility of some collaborative work with him and the cardiac population within Birmingham, but wider still the British Heart Foundation, which is currently in talks with them as well. So still work in progress, but definitely some exciting opportunities to move forward with. So thank you for having me today. Obviously, if anybody's got any questions, please let me know. Thanks for listening.
Thank you very much, Adam. I just always struck by Adam and Beverly how forward-thinking and all of the about their approach and how they're they've got so many great ideas about how things are running and the opportunities are already available. So I'm just absolutely hugely on board with all of that. So thank you very much, Adam. I mean, Mr. Motivator, I do remember Mr. Motivator as well. Just a point there. It would be good to have him. I'm just going to. If anyone's got any comments or chats in the meantime, just please put them into the box there, and we can do that. I'm just going to share my screen. So Adam, if you going there a minute, I'm just going to just show you just what we've got coming forward, really. So just bear with me. So just to go back, so obviously we'd appreciate your feedback. There is a link in the chat box, but also there'll be an email sent out to you as well. So really appreciate it. It's a very short survey, so just any of your comments, we really appreciate that. Any of the recordings, and this is the 8th webinar in the series of 11, they're all going to be available on the YouTube channel. Not all of them on there at the moment, but we'll have all of those on there very soon. Next week, we have got physical activity in people with disabilities. My senior colleague, Dr. Kim Gregory, who has a lot of experience in this area, is going to just give an expert overview of physical activity and people with disabilities. We've also got 2 speakers from the local area, from Midland Sailing Club, which is in the centre of Birmingham, Edgerton Reservoir, about the work they've been doing to adapt and accommodate people with disabilities and allowing them to sail. So I think that's absolutely fantastic. And also Midland Men Cap as well. They're going to discuss what they're doing in this area as well. So it'd be great to see some of you there next week. The final webinar it's going to be on the 5th of May. We're just finalising the content for that because it's not quite clear on the website, or the registration website. It's going to be an interactive discussion about all of the webinars, which covers physical activity in many different conditions and throughout the life course. And it's really an opportunity to say how, as Birmingham as a city, what is going to be the way forward there, and how we can work together to get people more physically active, because that's obviously, what these talks have come across is that we still have got a long way to go to get people more physically active, because a lot of people are inactive at the moment. So it'd be really great to have as many people as possible for that discussion that we're in our final webinar. Thank you very much for all your time today, and thank you very much for attending. Thank you.